Let me start by welcoming everybody and in particular thanking our panelists for taking time out of their schedule to assist us. I also want to in particular thank the leadership of ASPE, Sharon Arnold, who raised these issues that we're going to talk about in terms of anything the committee might be able to discuss that would be useful, particularly for states and others. So I'm going to give a little background in terms of the panel, which, as you can see, the topic is for us to really talk about COVID-19 in terms of capacity gaps and quality in the collection of race and ethnicity data. One of the things we know is that COVID-19 pandemic exposed a number of data gaps in our ability to be able to respond quickly and efficiently in determining the impact in racial and ethnic minority populations. So early in the COVID-19 epidemic, we had researchers, advocates, states really called out the lack of data identifying race and ethnicity in cases in hospitalization and death, despite the fact that this data is part of our reporting requirements. What it raised are issues about the methods of collection. What we saw was this issue about the lack of reporting and health data, electronic health records, and also in our mortality records. So the concerns that are raised are about the standards of incompleteness of health records, a lack of enforcement for completion in a timely manner. We actually think about this, lack of data quality due to incompleteness, and also the inability to link records in order to fill in missing data for national attention and leadership. For those of you who follow this issue, what you'll know is just yesterday, the Kaiser Family Foundation put out a brand new report on COVID-19 vaccinations in race and ethnicity. As of March 29, 2021, CDC reported that race and ethnicity was known for just over half of people who had received at least one dose of the vaccine. Among this group, nearly 2/3 were white, 9% Hispanic, 8% were Black, 5% were Asian, 1% were American Indian or Alaska Natives, and even less than 1% were Native Hawaiians or other Pacific Islanders. So the purpose of this expert panel today is to learn about the ways in which current practices and gaps in data collection, input, sharing, linkages, and analytic methods could be improved to address some of the health inequities that we see in COVID-19. The lack of race ethnicity data also impedes the capacity to identify outcomes that may actually be there in research, treatment, and helping us to identify evidence-based interventions at this subpopulation level. I'm going to turn this over to my co-moderator, Denise Love, who will introduce the panel and add any additional words of welcome. Denise, you're on mute.
I think those are the words of this pandemic. You're on mute. So thank you so much, all of the panelists, and thank you, Vicki, for opening this up. We've divided the panel into two parts. And the first part, panel A, will be talking about some of the inputs or the collection issues around race ethnicity data and some of their learnings and findings that they have been working with during this pandemic. And then the afternoon panel, or the part B, not afternoon, depending where you are, we'll talk about some of the solutions and some of the possible workarounds and where we go from here. So this morning's panel, and I don't have the order, Vicki, I don't have it in front of me, but do you want me just to do the bios for each of the panelists?
Sure.
Yeah. So we're hearing from Dr. Betty Birkmeyer, an endowed professor at the University of Washington School of Nursing, who is a nationally recognized public health systems and practice-based researcher, focusing on the structures and practices of state and local health departments regarding disparities and outcomes. The bios are available on the site and in the packets. So I'm not going to read the whole bio here. Then Vicki, will you take it from here because I'm missing some of the bios?
No problem.
Yeah.
Again, I think we've got them on the website. So what I'm going to do is introduce them by their titles. Trust me, they're great.
Yes,
Several of
yes.
them might
Thank
know.
you.
So we have Elizabeth Pathak, who is the director of the COVID Kid Project. She's going to be talking about measuring disparities in COVID-19 in children and teens, the problem of missing race and ethnicity data. We're also going to have Seth Spielman. Seth, did I say your last word? Okay. He's the Chief Data Strategy and Analytics Officer, and he's also an Associate Professor of Geography at the University of Colorado Boulder. And we'll talk about uncertainty in demographic and social economic data, the use of differential privacy for disclosure control, and its potential impact on age and race ethnicity count. Along with him will be David Van Riper, who is the Director of Spatial Analysis at Minnesota's Population Center. And in this panel, we will also have Alex Stokes, an assistant professor in global health at BU School of Public Health. And we'll talk about race, ethnicity, and the validity of cause of death assignment for COVID-19 in the US. In panel B, which is actually the solution one, I will be talking about a predictive model, asking the question of what it is that we need besides race and ethnicity. We will have Glenn Mays, who is no relation. We may look alike, but no relation. He's professor and chair of health systems management and policy at the University of Colorado. And we'll be talking about race ethnic data through cross-sector data sharing network. Michael is to talk about framework to improve mortality, morbidity, and disparities data for COVID-19 and other large-scale disasters, which was a discussion that took place at the National Academy. He's a professor of health systems administration and population health at Georgetown. And then Inez Ponce will talk about the implications for COVID-19 equity in not disaggregating data in Native Hawaiian and Pacific Islanders. She's one of my colleagues at UCLA Center for Health Policy and Research and the Fielding School of Public Health. I'm going to be the timekeeper for the first panel. And I just want to say to my colleagues, particularly those of you in Colorado and Dr. Ponce, who just lost her associate director of the center, that we really appreciate your being with us and being able to do this work during a time where, you know, mortality is really hitting you in other ways. So thank you for being here. So we're going to start with Dr. Pathak, who's going to talk to us about kids.
Good afternoon, everyone. My name is Beth Pathak, and I'm going to be speaking today about the problem of missing race and ethnicity data for COVID-19. While my particular focus will be children and teens, most of the problems I will elaborate on are true for all ages. Next slide, please. I'd like to thank the committee for the invitation to contribute today's panel, and I'd also like to acknowledge my collaborators on the COVID Kid Project, Janelle Menard and Becky Garcia at WISE, and Jason Salemi at the University of South Florida. Next slide, please. I'm going to move through my slides very quickly, so please do jot down slide numbers for any issues you'd like to return to during the discussion. And I tried to make the slide numbers nice and big so you can see them. Next slide, please. I'm going to focus today on 5 types of surveillance data that we need to understand the epidemiology of COVID-19 in kids. And of course, these points apply equally to adults as well. Click. So to understand incidence of disease, we need testing and case data. Click. To understand disease severity, we need hospitalization and intensive care admissions data. Click. To understand disease fatality, we need death certificate data. Click. To understand racial and ethnic disparities, we need all of these types of data. Next slide, please. So reporting of testing denominators is highly inconsistent across states, rarely stratified by age, and there is only one state that reports tests for racial ethnic groups by age, and that state is Illinois. And I will share some data from the state of Illinois with you later. Next slide, please. I will spend most of my time today discussing the problem of missing race and ethnicity data in COVID-19 cases. This is the bedrock that we need to calculate disease incidence rates. All of these data originate with state health departments who share their data in two distinct ways. They share directly with the public via their web dashboards, and they submit required data to the CDC. There's a great deal of mismatch between these two data sources. You'd think they'd be the same, but they're not. And I'm going to return to that shortly in a lot more detail. And an important point to note here on the side is that in the CDC case file, even though all states are reporting race and ethnicity, that's part of their requirement to report, it's missing for 45% of the cases. Next slide, please. Hospitalization data, we're in a much worse situation. As of this week, only 23 states report cumulative hospitalizations for children and teens on their dashboards. And none of these states report these data by race and ethnicity. I will share with you a few slides with the very limited data available from the CDC and the CDC case file. And I will note that the DHHS hospitalization file contains no race and ethnicity data for any COVID-19 patients. Next slide, please. We do have a truly excellent, but unfortunately incomplete data source for pediatric intensive care admissions of children 0 to 17 years old. This is a voluntary hospital registry, which was initiated as a public service at the beginning of the pandemic by a pre-existing registry called the VPS registry. And I really urge the committee and audience members to visit this dashboard, as it is an exemplar of rich clinical surveillance data on our most severely ill children. Next slide, please. There are three primary sources of death data: state health department dashboards, the CDC case line data file, which contains a yes/no death indicator, and finally, the NCVHS death certificate tabulations. As you would expect, because of delays in reporting and processing, death counts from the first two sources are much higher than what is reported by NCVHS. And I will just say here that I've been very impressed by and grateful for the speed with which NCVHS has released a large number of COVID-19 death tabulation files. Next slide, please. So now I'm going to share results with you for all 5 of these types of data focused on the availability of the race and ethnicity data. Next slide, please. In Illinois, for kids 0 to 19 years old, we can see in the chart on the left that there is a large difference in the extent of testing, with much more testing being done in non-Hispanic white kids. And please note that these tests, these are not numbers of people who have been tested. These are number of tests that have been done in this age group. So we're seeing multiple tests per person. It's not that 87.5% of white kids have been tested, but 87.5 tests per 100 kids in the population. The test positivity rate is twice as high in Hispanics versus whites, and the incidence rate is 25% higher in Hispanics. So understanding testing denominators and test positivity rates are really essential for estimating true incidence rates. And we need better person-level data for all states, and obviously by race and ethnicity. So right now, this is a very big gap in our data. Next slide, please. Now I'm going to talk about the case data. Next slide, please. Can you click a couple, just click all the way through one more. Okay. So in the COVID project, our case counts come from weekly manual extraction of child and teen data from 50 state health department dashboards, plus the District of Columbia and New York City. Our counts are higher and more accurate than reports you may have seen from the American Academy of Pediatrics, because we correct for substantial non-reporting by New York State and Texas, 2 of the 4 largest states in the union. So here we're interested in calendar year 2020, and we're comparing data from the COVID tabulations and the CDC case file totals. And you'll see that COVID has more cases than CDC, but the situation is a little more complicated when we look at the state level. So I click. All right, so this chart shows the discrepancy between the COVID case counts and the CDC case line file. And this is for calendar year 2020 cases. So in this chart, both of the axes are on a logarithmic scale. So pay attention to those numbers that you see. It's on a log scale. And the gray diagonal line represents perfect agreement between states. Okay, so when the states fall close to that line, the agreement is pretty close. And keep in mind that the CDC case file is for ages 0 to 19 years for all states, but the state dashboards vary in their reported age categories. Some report 0 to 19, some 0 to 18, some 0 to 17. So the states that you see that fall well below the line, well below the gray diagonal line, are states which are not reporting all of their cases to the CDC. And in some cases, they've reported very few of their cases to the CDC. So we know what they've reported on their dashboard, what they're submitting to CDC is just a fraction of that. And committee members can find more details about these comparisons and the states that have problems in the slide supplement at the end of my talk. So at the end of my PowerPoint file, there's some supplemental slides there for committee members to review. Next slide, please. So our goal was to assemble the best estimate of cases, and we combined data from COVID and the CDC case file to accomplish that goal. Can you click 3 times? Click 2 more times, I think. Okay. So as you can see, we used CDC totals for 13 states. An example is California, because on the dashboard, California only reports 0 to 17. So we picked up a lot of cases by getting the 0 to 19 age group in the CDC file. But for 38 states, the COVID total was better. Next slide, please. So after getting that best estimate of the total number of cases, we wanted to go back and impute race and ethnicity for those 45% of kids that were missing that information. Click, please. So we wanted to impute only at the aggregate level to permit calculation of cumulative incidence rates. Click. Unfortunately, we cannot recommend imputation at the individual case level because there are few variables available that in the file that allow anything beyond random imputation, which we just don't think is good enough. Because there's a high degree of missingness and there's not very many descriptive variables about the patients. Click, please. So at the aggregate level, our method for imputing is very simple. We simply assumed that the racial ethnic distribution of the missing cases was the same as the non-missing cases. And we did this at the state level. And there's some more information about the detail of the state level imputation in the supplement. Next slide, please. Okay, in the interest of time, I'm sharing the results for children aged 0 to 9 years only. And committee members can find the results for the 10 to 19-year-olds in the supplement. On the left, you can see the raw data from the CDC file with 46.3% of cases missing race ethnicity. After we corrected the total count, which increased by 160,000. So you see we went from 643,000 to over 800,000 kids. and we imputed race and ethnicity, you can see the case distribution, the final case distribution on the right. And remember that the imputation occurs at the state level. And at the state level, the racial ethnic distribution of cases varies widely, and also the degree of missingness varies. So that's why the percentages don't match between the left pie and the right pie, which are the national aggregates. And again, there's more details on this in the supplement. Next slide, please. Now, the point of doing all this is to understand the impact of this missing data on incidence rates. So you can see in this chart that there was a huge impact of what we did on the incidence rates. The striped bars represent the uncorrected incidence rates, and the solid bars are corrected. And you can see how much the incidence rate increases for several of the racial ethnic minority groups, particularly Hispanics. And I want to note here that, to my knowledge, CDC folks have not performed any race ethnicity imputation when they've published analyses of this case line file. So they've simply excluded the cases that were missing race and ethnicity when they were looking at race and ethnicity data. Okay, next slide, please. So now I'm going to move on to the national hospitalization data. And thank you. Let's see. Somehow my slides. So what you see here is data from the CDC case line file, that hospitalization indicator. And keep in mind that this indicator was missing for 59% of the cases, and race and ethnicity is missing for 45% of the cases. Now, we do think that probably, missing may mean no for some states, but the hospitalization rates that you can see here are, this is percent of cases that were hospitalized, 0.8% of whites, 1.5% of Hispanics, and 1.8% of the Black patients. And the total hospitalizations reported for kids was 19,000 in this file. Next slide, please. Now I'm going to talk about the National Intensive Care data. Next slide, please. You can just click through those bullet points, please. I think there's one more. Okay. So this shows data from the VPS registry, and this there were race and ethnicity data available for 2/3 of the patients, which is over 1,800. And you can see the distribution with only a little bit more than 1/4 of the patients were white, and nearly 3/4 were Hispanic, Black, or other racial ethnic minorities. And I would just like to emphasize that because this is a voluntary registry, we really don't know what the hospital non-participation rate is. So this is an undercount of the true number of kids who have been admitted to intensive care with COVID-19. Next slide, please. Finally, we have death data. Next slide, please. And what I would like to invite you to do is to visit the COVID Project Disparities dashboard. We have quite a bit of detailed mortality data courtesy of the NCVHS files that are submitted. Next slide. And this is an example of one of our dashboards. This is for children 1 to 14 years of age. We have the case distribution, mortality rates, and then the rate ratios with confidence limits. And you can see for this age group that both Hispanics and Blacks have a death rate that's over twice as high as what we see for white children. And we also have data for infants, teens, and college-age young adults on our disparities dashboard. Next slide, please. So now that I'd just like to summarize a few priorities that come out of this analysis. Next slide. Click. And if you can just click through these as I read them. Race ethnicity data without age stratification is a very limited utility. Most state dashboards report race and ethnicity data for COVID cases, but not stratified by age. And you really can't do much in comparing different racial ethnic groups if you don't also have age to either adjust for or stratify. Missingness of race ethnicity data needs to be systematically investigated and then actively intervened upon because it's still happening in 2021. So it's not like this is, just an early in the pandemic problem and it's all been fixed now. It hasn't been. We still have testing cases, everything with a lot of missing information. And we need to pin down what the source is and come up with either the incentives or the consequences to get it to stop. I would like to see an end to excessive suppression of data, particularly death counts. We see a lot of that, and it really impacts the child reporting. And of course, we're predominantly suppressing deaths that are occurring among minority children. Next slide, please. Priorities for states include expand state dashboard reporting for kids, use standardized cut points and definitions to improve comparability among states. There's so much variety in what states are reporting, it makes it really hard to compare and contrast across geographic areas. We need to include vaccination, testing, case, hospitalization, and death data. Report all data items by race and ethnicity. And we actually have a report card on the CoKid project website that goes into little detail about grading states on the quality of the data that they're currently reporting. Next slide. We need mandatory hospital reporting of all COVID-19 hospitalizations of kids with demographics, length of stay, and discharge disposition. We need expanded clinical registries for all intensive care hospitalizations for kids. And we need emergency department visit registries. This is something that folks may not have even thought about, but this is an important nexus for access to the healthcare system, especially for racial and ethnic minority children. And it's something that we're not keeping track of at all, except for one exception, which I'll share with you in just a minute. I think that's, yeah. So now what I'd like to do is share some information from the state of Florida with you to get you to imagine the possibilities. This may come as a surprise to some of you because Florida is often in the news in a negative way, but I will tell you with great assurance that Florida has the absolute best and most transparent COVID-19 data releases in the country. The state of Florida releases a COVID-19 case line data file every single day of the week, 7 days a week. And this has nearly 2 million cases released to the public on their website, no restrictions. My colleague, Dr. Jason Salemi, who's an epidemiology professor at the University of South Florida, publishes a daily dashboard with over 75 detailed metrics and maps and charts on every aspect of what's going on in Florida. And the great thing about releasing this data to the public is that it permits the vast scientific expertise and resources that exist outside of government agencies to get to work on this problem. When we don't release data, then we're putting all of the burden on government scientists. And frankly, there simply aren't enough people and resources to do everything that we need to have done.
Beth, you've got about a minute left.
Okay, good. Next slide. So this is just a screenshot from Dr. Salemi's dashboard. And it's a little bit tiny print, but you can see that that they actually release data in Florida on ED visits. And for patients of all ages, there have been over 125,000 emergency department visits for COVID-19. And you can go in and select this by age, by county. There's a great deal of flexibility here. But of course, and I'll just end on this note, the bitter irony here is that as wonderful as this data resource is from Florida, the one thing that is missing is the race and ethnicity of the cases. So we still have a lot of work to do, but I really encourage you to visit these dashboards that I've given you links for so you can see what some of the possibilities are of what can be done. Next slide. So thank you for your attention. Please feel free, anybody who's listening, to contact me with any questions. And you have my email address there and also the COVID Project website. Thank you.
Beth, thank you very much. That was very informative. So let's move to Seth and David.
You can jump to the next slide. So David and I are going to be talking about national sources of race ethnicity data. So we're going to be talking about information that is available from the US Census Bureau for sort of the entire country. We're not going to be talking specifically about COVID-related data, but we are going to be talking about the data that really informs denominators anytime you want to calculate a rate. And in particular, we're going to be talking about what we think of as the two primary sources of race ethnicity data in the United States. The first is the American Community Survey. The American Community Survey is, as it says in its title, it's a survey, not a census. So it's a sample of about 3.5 million housing units in the United States each and every year. The survey has about a 60% response rate. And because it's a survey, there's uncertainty associated with the counts that come out of the survey. So if the American Community Survey had a different sample on a different day, we would expect some changes in the counts. And so there's some uncertainty in those estimates. And we're going to talk in some detail about the magnitude of the uncertainty in the estimates of race and ethnicity. The second source of information that's available from the Census Bureau is the decennial census. The ACS is a sort of annual snapshot of the country. The decennial is a once every 10-year snapshot of the country. However, unlike the ACS, as we all know, the decennial is, at least in theory, a complete count of the American population. The key thing that we want to emphasize about the decennial is that the published data from the decennial have always, or at least in modern history, included some obfuscation of the data to protect privacy. So particularly for sort of smaller geographies like neighborhoods or counties, there's actually, for neighborhoods, there's swapping the data is directly manipulated by the Census Bureau to protect individual privacy. And in 2020, the Census Bureau is adopting a new approach to privacy protection, which is sometimes referred to as differential privacy or a formal approach to privacy. And that new approach involves injecting noise directly into the data. And that injection of noise affects your ability to understand, in particular, small populations. So racial and ethnic groups that are not a large part of the population in a particular place. And we'll talk about that in some detail. Next slide, please. So I'm going to be showing you a series of graphs. Sorry about the X and Y axis. I'll explain what those are. This particular graph that we're looking at here shows us the Hispanic population for almost every census tract in the United States. We've truncated 5% of the data just because there's some outliers. So each blue dot on this graph is a census tract. On the X-axis, we have the Hispanic population. So the number of Hispanic people living in that census tract. On the Y-axis, we have the margin of error associated with that estimate from the American Community Survey. So the red line represents cases where the margin of error is 100% or more of the estimate. So that would mean the American Community Survey was telling us there were 100 Hispanic people in a neighborhood, plus or minus 150 or 110, right? The margin of error is actually greater than the estimate, which means that there's somewhere between 0 and 100, 200, 500, whatever the number is. The yellow line on the graph represents cases where the margin of error is 50% or more of the estimate. So any blue dot that's above that line represents a place where the American Community Survey is telling us that the Hispanic population in the neighborhood is 100 people plus or minus 50 or plus or minus 60. And that green line on the bottom represents census tracts where the margin of error is 10% or more of the estimate. So when we look across all census tracts in the United States, for the Hispanic population, we see that 15% of all census tracts have a margin of error around the count that is greater than the estimate. So in 15% of all cases, the American Community Survey tells us something like there are 100 Hispanic people in this neighborhood, plus or minus 150. So we know there's somewhere between 0 and something. In 50% of all census tracts in the United States, the American communities, the margin of error on the Hispanic population counts are 50% or more of the estimate. So there's still quite a lot of uncertainty for the Hispanic population at the neighborhood level when we look at the United States as a whole. Key thing to notice is that many of the things that are sort of above the red line represent cases where the population count is small. As we look at neighborhoods that have larger Hispanic populations, in general, the amount of uncertainty as a percentage of the estimate tends to decrease, but it's still often fairly high. The margins of error are often, over 10% of the estimate. If we go to the next slide. So here we're looking at the exact same plot, same idea, same logic, just that we're looking at the total population of the census tract. And what we see when we look at the total population is that very few census tracts in the United States have an extreme amount of uncertainty around the total population. Very few are in that sort of medium category, and about 35% of census tracts have a margin of error for the total population counts that is 10% or more of the estimate. So there's still some uncertainty in the total population, but it's not nearly as much as when we start to look at subgroups of the population, is the key takeaway. And if we go to the next slide, I won't talk through all of these because just because of time, but here we're looking at the large sort of racial categories that are reported by the census. So if we look at the African-American population in the United States, about 26% of all census tracts have a margin of error that is greater than the estimate, which makes the data very hard to use because it's somewhere between 0 and something. For Native Hawaiian Pacific Islanders, it's about 90%. For the Asian population, it's 40%. For the American Indian Alaska Native, it's about 80% of census tracts have a margin of error that is greater than the estimate. Now, census tracts are a very small geography. Census tracts are useful if you want to look at intrametropolitan variation. If you could go to the next slide. If we zoom out and we look at the quality of these estimates at the county scale, the data gets better. So at the county scale, here we're looking at the Hispanic population using that same sort of type of graph. Only 3% of counties in the United States, when we're looking at the Hispanic population, have a margin of error that is greater than the estimate. And almost all of those are places where the Hispanic population is relatively small. 10% of counties for the Hispanic population have a margin of error that is 50% or more. And 13% of counties have a margin of error that is 10% or more of the total population. If we think about the other ethnic groups which are included in the notes for these slides, for African Americans, it's 12% of counties have where the county estimate of the African American population from the ACS. In 12% of all counties in the United States, the margin of error is more than the population count. For Native Hawaiian Pacific Islanders, it's 80% of counties. For American Indian Alaska Natives, it's 30% of counties. So for lots of racial groups in the United States, even at the county scale, our estimates are highly uncertain. If you could go to the next slide. I won't dwell on this slide too much. This is showing similar data. This is from a paper on this topic that we've published in Demography. The key thing to realize here is that as you move into subpopulations, so if you look at the Hispanic population, the uncertainty is it's fairly large. But if we were to look at sort of an age-specific group of the Hispanic population, or in this case, an age and gender-specific group of the Hispanic population, the uncertainty around those around those counts gets higher. Even at the county scale, we see, which are these diamond symbols, even at the county scale, the y-axis here you can think of as the amount of uncertainty. Even at the county scale, we have a fair amount of uncertainty if we wanted to determine, say, the number of Hispanic women who are over the age of 65. So across the denominator, these denominator type data from the US Census, we see high levels of uncertainty. Next slide, please. There's this sort of Goldilocks problem where census tracts have very uncertain population counts, but they tend to be very small geographies. If we zoom out to counties, we often get good data, but if you're a health service provider or a state agency that wants to look at intra-county variation for the purposes of program planning, all of that intra-county variation is lost. So there's really not a good sort of middle scale geography. New York City has created their own geographies for reporting and analysis. We've developed software and a website to allow people to sort of create their own geographies. If we had more time, we could talk about that. We won't here. And there are other methods to use the published data from the ACS to refine estimates, which again, because of time, we won't be able to talk about. But there are fixes, but there is a real problem with getting denominator data from the ACS, in particular when you look at racial groups, and that problem is compounded if you looked at age-specific or gender-specific racial groups. And with that, I'll hand it over to David.
Great. Next slide, please. So now I'm going to switch and talk about the decennial 2020 census and to talk a little bit about this new disclosure avoidance method the Census Bureau is going to implement, and look at the impacts that it's going to have on counts of sex and age groups, and by extension, sex by age by race groups, and think a little bit about what that means for users in the long run. Next slide, please. So as Seth mentioned earlier, the Census Bureau used to use a technique called swapping, which you see on the left here. And in swapping, they would target households and individuals who were particularly outliers, right? There was a couple of families in a census block that was Asian and Pacific Islanders, and the remainder were all whites in that neighborhood. They would try to swap some of those households between census blocks to protect their privacy. But it was a very opaque system. The policy decisions that went into that, the Census Bureau can't talk about, because you can reverse engineer the swapping if you know what types of characteristics they're matching on and where they're doing their swapping. So in the 2020 census, they're developing a differentially private method for doing disclosure avoidance, and that involves noise infusion. So in noise infusion, you're perturbing most of the counts to protect the privacy. And the Bureau's noise infusion method is designed such that the magnitude of the noise is completely independent of the cell count. Thus, we can observe situations like the tripling of the female never attended school on the right-hand side because of that noise injection. This noise is drawn from particular statistical distributions whose shape is controlled by policy decisions made by the data producers. Next slide. The policy decisions related to swapping are not publicly disclosed, but I want to talk a little bit about the policy decisions related to the differentially private algorithm, because the one benefit of the differentially private method is that all of those policy decisions can be made public. This transparency is useful because we'll know more about the disclosure avoidance, but on the flip side, those policy decisions can become political, potentially political. And the way to think about these policy decisions is that the Bureau has to establish something called a privacy loss budget. And they then spend that budget on various parameters. And the more money, the more they spend on a particular parameter, the more accurate the statistics will be for that geographic unit or table. The less they spend on that unit, the less accurate it's going to be. Next slide. So for thus far, the Census Bureau has released a number of demonstration data products, and And they've been targeting the geographic units you see here that I've circled in the gray boxes. So they've been focusing their spending of the privacy loss budget on states, counties, tracts. Anything in the off diagonal has not received an explicit allocation of the privacy loss budget. So we tend to see less accurate counts for those off diagonal units and more accurate counts down the middle. Next slide, please. In addition to the geography, they have to decide which statistics, which queries do they want to make more accurate. So in this particular example from some early demonstration data, the Bureau decided to make the voting age by Hispanic by race data the most accurate, and they had made the sex by age data the least accurate because they were privileging the redistricting, the political redistricting application of the data. Next slide, please. So now I want to show just a couple of results of what can happen when you see these counts come out. Next slide.
We got about
So
a
this
minute,
is,
David.
yep, this is the census tract that I live in here in St. Paul. The red and blue boxes are the counts of individuals by sex and age for single years of age from the SF1 2010 data. The black dots are the counts of those sex by age groups from the October 2019 demonstration data products, and the green triangles are the same counts from the May 2020 demonstration data set. And if you look, for example, at the count of people under the age of 1, you'll see that we had about 40-ish of those males and females in my tract in 2010. The October demonstration data set showed almost no infants in my neighborhood, and the May data set showed a more similar counts to what were published, but that doesn't always hold. Next slide, please. Even if you go up to a different set of age bins, so these are 5-year age bins, each group is a 5-year age bin, we still see uncertainty in the counts, comparing the red bars to the dots that are above it. Next slide, please. So I'm just want to get a real quick real world example for public health. Go to the next slide, please. What we're comparing here are asthma ED rates for Massachusetts towns. We're comparing rates of SF1 versus other denominators. You can just see the uncertainty here by the size of the place. So the smaller the town is, we know very little about the age adjusted rates. And as we make the sizes bigger, we get more consistency between the data sets. Next slide, please.
We're getting out of time, David.
Okay, so these slides will be available, but just know that things are changing quickly. The Bureau is making lots of decisions about this, and we're going to learn more over the next 6 months. So you should always be paying very much attention to what the Bureau is doing over the next little bit. Thank you.
Thank you very much. Sorry we had to rush you there, but let's go to the next presenter, Dr. Betty Backmeyer.
Great, thanks. Thank you for having me. So my presentation will be a little different. It's less about the data themselves and more about local and rural public health perspective and the needs of the public health practice system in rural areas in particular. But so next slide. When we talk about, I want to situate this presentation, clarify that I'll be talking mostly about governmental local public health departments. And that's because in this definition of what we call a functional local health department, they have pivotal positions in population health improvement and promoting health equity and reducing disparities. And these local health department leaders, they are expected to use and contribute to the evidence base for public health. And we should be expecting them to provide expertise within their communities regarding promoting health equity. They're often the hub, especially in rural areas, for addressing health issues of equity, and the ones that communities look to for data, for information, for support around community decision-making and equity, and in particular, local public health emergencies. So next slide. So some of this for me started back in the 2008 massive budget downturn. And in Washington State, we were hearing horror stories of local health department leaders making really super painful budget cutting decisions, like overnight. So we did a study about how are these decisions being made. And the long and short of it is that all of our study participants talked about wanting to use data and evidence, and they brought this up, but that the data were not available. They didn't have capacity to look at the data. They'd had to lay off their data guy, whoever their data guy was, who knows. And there were more dominant other forces, as shown in this figure, that were at play. But to a person, they all talked about the very small role that data made in decision making and how much they wish they had better access to data. And that has not changed much since then. So next slide. I'm going to distinguish a little bit between public health administrative data and community data around public health status. And they are both critical to addressing health equity and particularly problems in rural areas. But to try to compare for administrative data for public health agencies, they want to compare their agencies against others. And this is part of figuring out what are the best practices to measure public health impact of other services and resources. And basically, it's not possible. No standard exists for the approximately 2,800 local health departments across the US for measuring their prevention activities or even expenditures. We've been working a lot on that, but we're far from it. This lack of comparable data limits the extent to which policymakers, researchers, public health practitioners can generate the evidence they need to make data-driven decisions. And that includes response to the COVID pandemic, and this is exacerbated dramatically in rural communities. Next slide. So around public health status, here's another project we've been working on we call Share Northwest, but we focused in this project only on rural local health departments, and in particular in the four Northwest corner states. And many of these gaps in data access that you see that we've found here, that we've identified, are true for non-rural public health agencies, but they are particularly acute in rural areas. More recently, we went back and interviewed rural public health leaders about data gaps during COVID. And if you could click right now, there, great. Here's what they said, that the data, they had access to data, better access to data, but they were overwhelmed by the data volume. Public health practice leaders were. It was more than they could manage or handle. They questioned the data trustworthiness. They had lack of capacity for assessing it, ensuring its quality, for communicating with these data. And then they really lacked data for specific underserved groups. So it was all compounded for them during COVID. Next slide. So over the years, as our team, the Public Health Activities and Services Tracking, or FAST team, has worked on data issues and related research for health departments, we've developed this model. Now, this model really represents the needs of governmental public health practice people and depicts this kind of virtuous cycle of factors necessary for integrating standardized administrative data into public health systems, as well as supporting deeper data use and access. So these three different red-headed buckets here are all very interrelated, and all need to be attended to really address some of these gaps. And that's really been found for us in our work. Next slide. Next slide. For public health practitioners, they really have a need for access to relevant data, and it's often expressed as a need for those data for planning, for decision making. And access doesn't mean like giving a bunch of spreadsheets to them. That's not access. They can't use that. They'd also like to be able to better use the data they have, and they talk about their need, their challenges, their potential use of data are all critical to designing effective strategies for community health improvement. So through our work with public health practitioners over the years, they've really described, old data reporting systems, lack of centralized systems. And when the data are collected, it's often done by several different agencies or state public health divisions. So they have to get data from numerous different places. They question its quality. And when they want to answer newer pressing problems, like with the opioid epidemic, now COVID, et cetera, the data have often not existed to even lend themselves to understanding the degree of the problem and looking at differences among marginalized populations. They've also talked about the lack of expertise in their agencies for using data. And then in terms of understanding how data are used and how they want to use them, they always talk about wanting to be able to use data to better communicate within their communities, with their boards of health, et cetera, with elected officials, and for discovering where the needs are for specific populations. Next slide. So part of this is on us as researchers too, in the generation of data, and our primary activity has been to set up standardized data measurement systems and collect relevant data, make use of them, and present them back to and work with our practice partners around making these data more useful for generating evidence, et cetera. So we've worked with a lot of existing administrative data with health departments. I've done a lot with that, and done some important research that analyzed data that's with questions driven from practice. But it's a tremendously huge task. It's no small task. There are great limitations to these data, et cetera. So it really underscores this sort of iterative nature. You have to work with practice, but it also underscores the need for standardized data. Next slide. So this last piece of the model is really about bridging this gap and really highlights data access. It explains that you have to provide a bridge between research and practice that really provides these channels to make data accessible and usable, et cetera. We've looked at and are working on things like centralized data reporting, user-centered designed data visualization to make the data really truly accessible to practice people. To providing that training and education to build capacity, et cetera. And all of these channels need to be effectively attended to. Next slide. So with some of our current funding, we've, on the left are those data gaps. And with our current funding, we're trying to address some of these more immediate solutions, at least in rural areas in our region. And addressing some of these gaps. I won't go through them all, but you'll note that a lot of the sort of low-hanging fruit here is in the form of this capacity building and providing training and helping folks make better use of existing data. And we've been doing a ton of data linkage of data from many, many different sources and make it more useful to people on the ground in their local decision-making. Next slide. But finally, in terms of sort of larger, broader solutions, our lessons learned regarding improving data use specifically for rural public health is that sort of on the administrative side, it's better data are really critical for more equitable resource allocation, for really sort of being able to see where resources are going and how they should be allocated. And that requires data standardization. Such data standardization requires a substantial resources and time, coordination. It frankly needs to be mandated. There need to be incentives involved, et cetera. We've been working a lot around that. In terms of public health status data, data need to be accessible for people who are doing the work in these local communities, especially in rural areas. And just providing, Excel spreadsheets is not accessibility for them. There needs to also be training and using the data, collecting more data, sharing and engaging around those data with their communities, and then resources for oversampling and data collection. And Dr. Pathak mentioned it too earlier, that the whole issue of suppressed data for small numbers in rural communities is a big issue for them. And that kind of gets to the oversampling piece or the data collection. Rural public health officials often only see asterisks where the small numbers of data are suppressed. So when they want to explore variation by race and ethnicity, their hands are often tied around that. And even sometimes in terms of more general data. So we need to find a solution for this too, at least for somehow making these data more available to public health officials. And here's references on these slides, and I'm all done.
Great, thank you very much. It was very informative. The last presenter in this part A is Andrew Stokes. And Andrew, want to get started?
Thank you. Can you hear me?
Yes.
Okay, thank you, Dr. Mays, for the opportunity. I'm really pleased to be here. I'm very excited to present some of our findings to this group, this distinguished group, and thank you for the presenters who've gone so far. I want to preface this by just giving the bottom line of our findings, because I think, you know, with endless Zoom calls all day long, we all tend to lose focus over time. So let me just start by saying that our team is looking at small area patterns of excess mortality in the United States across counties. And we are finding that the racial and ethnic disparities in COVID mortality are significantly underestimated when we rely on the official NCHS tallies. When we use our various methods and tools for incorporating excess mortality, we are seeing much larger disparities for Latinx individuals, for non-Hispanic Black individuals, and for Native American individuals. And so there's an imperative here to get these data out there as soon as possible to really to demonstrate that we're not getting to the full extent of the mortality crisis that's unfolding and the way that it's affecting different groups differently. So let's move on to the second slide. So I will talk about different types of excess death estimators, how many excess deaths have occurred, what is known about racial disparities. I'll talk a little bit about our forthcoming findings, which are coming out in PLOS Medicine and in several other journals. And then I want to talk about, why there are racial and ethnic disparities in underreporting, like why are the death certificate data not getting it right for racial and ethnic groups, and what are those mechanisms of underreporting? And then I want to talk a little bit about future directions for research. Next slide, please. Thank you. Next slide. So excess deaths are defined as the difference between the observed number of deaths in a specific time period and expected number of deaths in the same time period. There are a lot of estimates now of excess mortality at the national and state level, and what I think we need to really to do as a next step is to create these estimates at the county level so that we can really drill down to what's happening at the across local areas of the country. Next slide, please. So, in thinking about excess mortality, we have directly assigned deaths. Then we have excess deaths that were not assigned to COVID-19. Many of these deaths are misclassified to other causes of death, such as circulatory diseases, to Alzheimer's disease and related dementias, to an unspecified garbage code category, and to other causes. There are also indirect deaths that are related to interruptions in healthcare services, interruptions in the provision of acute healthcare, emergency department visits, as well as these broad social and economic consequences of the pandemic, effects on social isolation and loneliness, and so on. Next slide, please. So we know, based on NCHS estimates that as of 3/20, we had approximately 526,000 deaths, an unacceptable number of deaths due to COVID as a result of the direct effects of the pandemic. So these are the direct official tallies as of 3/24. Next slide. We also know that there are clear patterns in misattribution of deaths to other causes. We can see that there are excess ADRD deaths, there are excess diabetes deaths. So we have some sense of where these deaths are ending up. One thing that we desperately need to explore is the kind of the mechanisms that explain why these deaths are ending up in these other categories. And we ought to spend more time looking at these garbage codes, which might in some cases indicate, to be frank, foul play. Sometimes deaths may be misclassified due to political motivations, and we need to uncover those and to get to the bottom of the story here for excess mortality across local areas. Next slide, please. So we also know that there are these indirect deaths. emergency department visits have declined significantly, especially early in the pandemic. This is a MMWR report that I think probably everyone saw. And we can see that these declines occurred for many serious reasons related to acute care. Next slide, please. So what do we know at the national and state levels based on kind of the best evidence we have so far from the NCHS, from Weinberger, from Wolf and others? You know, we gather that about 22% of all excess deaths were not assigned to COVID, according to Weinberger. Next slide, please. If we look at NCHS-based estimates as of 3/30, they present a range of excess deaths between 538 and 655, and the percent of excess deaths not assigned to COVID, they estimate is somewhere around 20%, which is fairly consistent with Weinberger. Next slide, please. So what is known about inequities in COVID-19 deaths? A lot is known about inequities in the official tallies. We have you know, great evidence about this. So here's data from the NCHS on the percentage of COVID deaths by race and Hispanic origin. Next slide, please. We know, you know, as others have discussed in this panel and has been widely discussed among experts in racial and ethnic differences, it's very misleading to look at crude death rates when it comes to racial and ethnic differences. We have to age standardize. And as you can see here, once we age standardize or stratify by age, you see, you know, that really alarming differences emerge for Hispanic and Latinx individuals, for non-Hispanic Black, non-Hispanic American Indian or Alaska Native, and non-Hispanic Native Hawaiian or other Pacific Islanders. So there's really problematic differences here that we must not get lost in the narrative. Next slide. So here's a preprint that we have online that's forthcoming in PLOS Medicine. And what we want to try to add to the conversation is this kind of drilling down to the county level, because there's just only so much we can learn from state level data. And if you look at the other papers on excess deaths, really very few of them have been able to look at kind of social structural factors that are related to excess mortality, because at the state level, you just don't have the detail. There's some exceptions. There's, for example, some wonderful work being done in California by Kirsten Bibbins Domingo and Maria Glymore and that team that's been looking by race and ethnicity and occupation. There's great work by Elizabeth Wrigley Field and colleagues in Minnesota, but by and large, most of the excess mortality estimates do not give us a lot of information on the determinants and patterns. So that's what we hope to add to this conversation. Next slide. So we ask, what are the total number of excess deaths? We also ask, how does the percentage of excess deaths not assigned to COVID-19 differ by county level factors? So we're really interested in these kind of mechanisms of underreporting. Next slide. I'm going to skip most of this, but we take advantage of the spatial variation in COVID-19 mortality across US counties to estimate its relationship with all-cause mortality. So we're looking for signal, this imprint of COVID-19 and the impact that it's having on patterns of all-cause mortality across counties. Next slide, please. We use NCHS provisional county level data from January 1st to December 31st. We allow for reporting through March 12th in order to build in you know, lags in death certification. We also construct a historical comparison period using data back to 2013 from CDC Wonder. Our county level covariates come from the RWJ County Health Rankings Project and other sources. We have US Census population estimates for historical years, as well as by special request for more recent periods. And we explore model stratification by quintiles of county level factors in order to look at the social and structural factors associated with underreporting. Next slide, please. So here are the counties in our data set. In this current paper, we use a data set consisting of about 2,000 counties, which are counties with 20 or more direct COVID deaths as of March 12th, but for the period of 2020. So you can see we still have some gaps in these data that we're able to fill, you know, as we go forward with more recent data. Next slide. So here's the basic relationship between direct COVID and all-cause death rates in 2020. There would be no excess mortality over this period if all the observations fell on the black line. But as we can see, in aggregate, the relationship is off that line. It's higher, the slope is steeper, which suggests that there is this gap, there is this discrepancy, and that there are excess deaths occurring, which is not surprising. And when you stratify that by region, we're seeing a great deal of underreporting in the South and the West. Those seem to be particularly problematic with respect to underreporting. Next slide, please. Overall, in aggregate, for every 100 deaths assigned to COVID, the number of all-cause deaths rose by 120, suggesting that 17% of all excess deaths were not directly assigned to COVID-19 on the death certificate. So this estimate is very much in line with Weinberger and other NCHS estimates based on other methods. So we are reassured that our approach is kind of replicating findings of other studies, and we can break it down. 367 directly assigned deaths over 2020, 74,000 of these unassigned deaths, as well as leading to a total of 441,000 excess deaths in 2020, and we have confidence intervals around these estimates. Next slide.
You've got about a minute.
Okay, perfect. Next slide, please. So to get to the bottom line, if you look at non-Hispanic Black, and you just look at the blue line is the observed direct COVID-19 death rate. You can see that it appears that Black communities have lower COVID rates than white communities based on crude mortality rates. But the minute that you factor in the hidden deaths or these uncounted deaths, very stark patterns emerge with higher disparities between Black and white communities. Next slide, please. Next slide. Next slide. So I want to talk. I want to end this presentation with some mechanisms. So why are Black deaths and deaths among minoritized populations being differentially underreported? It could be differential access to testing and healthcare may make it less likely that residents receive a COVID-19 diagnosis before they die. Next slide. It could be a higher prevalence of comorbidities due to racial inequities in health may make accurate cause of death assignment less likely. Next slide. It could be more indirect deaths occurring in Black and Brown communities due to the social and economic consequences of the pandemic. Next slide. It could also be bias in death investigation systems. The death investigation system in the US is irregular, with some states relying on state medical examiners, while some counties rely on county-based medical examiners, coroners, sheriff coroners, or justices of the peace. Coroners in particular are often elected officials with little or no medical training. And furthermore, there's potential for interpersonal bias and political attitudes about the pandemic, which could influence whether COVID-19 is included on a death record or whether post-humanist COVID-19 testing occurs. We're very concerned that in some areas, coroners, have really come out saying COVID is a hoax, and we really have to wonder whether they're willing to assign COVID to the death certificate. Next slide. The final slide here is home deaths. Areas that have more underreporting of COVID-19 deaths could represent counties where a greater percentage of deaths are occurring at home. Dying at home could increase the likelihood that a death certifier or coroner would be involved in the death investigation process and decrease the likelihood that COVID-19 testing would occur. Thank you for the time.
Thank you. Vicki, should I take it from here?
Yeah, thank you very much.
We may leak over a little bit into our break because I'm fascinated. This is an excellent panel. Panel A, as we indicated, identified some of the gaps and challenges we have, and COVID has exposed those. And what we hope to accomplish with this next panel, panel B, are practical solutions to maximize what we do have, to gain insights that we need now. I wanted to add one more panelist that got left out of the introductions is Dr. Mark Cullen, the founding director of Stanford Center for Population Health Scientists, retired. We will start with Vicki Mays from NCVHS, then go with Glenn Mays, Mike Stoto, Ninez Ponce, and Dr. Cullen. So Vicki, I'm just going to turn it over to you right now to open up.
Great, thank you very much. What I'm going to try and do is to really focus more on the conceptual part and less on the results. The reason that I started this work is that when the epidemic first began, it was the issue of pre-existing health conditions. And many racial and ethnic minorities who were obese or had health conditions felt they were being blamed. And we knew that one of the things that everyone was asked to do is to figure out an equity metric. The biggest issue that everyone is struggling with right now is what is the best equity metric to use? Next slide. So part of what we did was took LA County, which of course has a very large and diverse population and has lots of different subpopulations. I worked with the UCLA Center for Neighborhood Knowledge, my colleague Paul Ung, who is an urban planner and an economist by training. Next slide. What we did was decided what are the things that put people at risk. So the big issue for us that we think is the way going forward is to think about vulnerability and risk to becoming infected, as opposed to just kind of a spatial orientation of this is where cases are. So what we did was we developed this medical vulnerability indicators, which had these 4 things that we thought were very interesting in terms of being able to capture kind of social risk. Next. So here, when we did pre-existing health vulnerability, part of what we did was we used at the time, this was actually done back in November. So we used the available scientific literature to say, what are the health conditions that seem to be associated with coming down with COVID? And then we also checked with some of our health experts who were working in the emergency room and other places where they were actually seeing the cases in case things were not getting to the scientific literature fast enough. In addition to actual health issues, we also included health status, we included mental health, and we included food insecurity, because the Pulse survey was telling us food insecurity was a very significant factor for people who had COVID-19. Next. We did barriers to accessing service as one of our equity models, but it isn't what you usually think of as barriers to accessing service, because it wasn't just about health services, but we were looking at lack of broadband access. We looked at whether or not people had a vehicle. LA is huge, and so if you're getting on public transportation, you're going to be more exposed than if you're in your own vehicle. We looked at, limited English proficiency, lack of health insurance, and citizenship. Next. This was also probably, if I had to say what works best of all things in our model, it has a lot to do with the built environment. The density of the population, the extent to which people are on top of and close to each other, the extent to which the building structure that in communities are housing really close to each other, and what's the density of that housing structure? Are these apartment buildings, housing projects, et cetera, with lots of people? And then we looked at the in-unit housing crowding, because in LA County, as in most of California, rents and mortgages are very expensive. And so you will see more people living together. But we also have racial and ethnic populations that have 3 generational households. And so again, this issue of being able to do the public health advisories are sometimes not as easy as people think. We used a very interesting data set called the California Parks and Recs data set, in which we looked at the availability of open space, the extent to which people can go out to walk, to be able to do that and not be on top of each other. Next one. Then, of course, as required by CDC and many others, we had the social vulnerability index. We actually used CDC's social vulnerability index, but what we did was that it was only available at the census tract level. Our data, for example, was available at a ZICTA level. So, we changed, we adapted it to be able to use the data that we had. And here what we're looking at is social economic status, the household composition, minority status and language, housing type, and transportation. So you can see that in essence, we created a model that has to do with vulnerability to exposure, and then that exposure being, the extent to which that person is likely to become infected. I'm just going to show you one of the outcomes of it. So can I have the next slide? So here's mapping. So we had we mapped in LA County what areas have the highest vulnerability for exposure and hence becoming infected. And our mapping has been used and is being used by, a variety of entities within the county to try and understand where should we be putting resources. So where should testing be? Where should vaccine distribution being rolled out? Next map. Here, what you can see is we can give you space using the variables we have, but we can also do population. So for pre-existing health vulnerabilities, what you can see is which of the populations are most likely to have that. So in essence, if what you do is really combine the notion of the racial ethnic population and then the area of vulnerability, what you're getting is the ability to really target quite well where to go, where to roll out resources. So I'm going to just quickly show you the other maps just so, and so that you can see them. This is barriers to accessing services. So if we're going to do a fix, we can determine what the fix needs to be by area. Next. We can determine who that fix should be. Next. This is our built environment. What you notice is the map now looks very different than it did in the beginning. And so you can see that built environment is not an issue for everyone because the housing will vary significantly by income. Next. And then again, you can see, the differences here in terms of who this is likely to be an issue for. And then let's just do the last one on CDC's adaptive social vulnerability. You see our map again begins to change. Next. And you begin to see who's similar and who's different. So this really allows us to be able to roll resources out very specifically to particular groups in particular places. So I'm gonna stop there, Denise, and hope that, we are, I get us.
I wish we had all afternoon, yes. And so now we're going to move right on, I'm sorry, to Dr. Mays, the other Dr. Mays, and for 10 minutes, and then we'll just keep rolling and then have discussion at the end, and I hope we have time.
Fantastic. Greetings. Thanks so much for letting me join this panel. Really great discussion, very important issues here. I'm going to focus in on another potential solution that has come up in some of parts of other people's talks today, and that is thinking about community networks as a potential solution. Networks of community-based organizations working together to resolve health and social issues for their communities as a potential solution, both in collecting better data on race and ethnicity, but also in using that information to actually reduce health risks associated with COVID-19 and other large-scale health events. So next slide. Part of much of what I'll be sharing with you today is data information that comes from the National Health Security Preparedness Index that allows us to measure the strength of preparedness activities that exist across the country and states and communities, understand how that varies over time. And in particular, I'll share with you some of these data that help us understand the importance of these multi-sector community networks and coalitions, the relationships that exist across community organizations working in healthcare, public health, and social services, and what we know about what role those networks play in actually preparing for and responding to large-scale health risks like COVID, but also other health risks. And then importantly, what the implications are for having better data on race and ethnicity to empower those networks to do what they do best in helping to protect communities from these kinds of health risks. Next slide. So one of the reasons why we might want to focus on networks is we think about the kinds of activities that we use to prepare for and respond to large-scale health threats like COVID-19. These are many different kinds of capabilities that are needed at the community level, and no single organization can do all of these things in public health, in medical care delivery and social services. And so we really need to think about collective actions, and networks are a way of supporting collective actions, helping to facilitate communication, coordination across organizations at the community level. Next slide. The Health Security Index is an index that was launched now about 8 years ago, originally by CDC, to measure the strength of these protections, capabilities that are needed to prepare for and respond to large-scale health events. The early work on this index was conducted under the auspices of CDC for the last 5 years or so. This is an index that's been produced and refined with funding from the Robert Wood Johnson Foundation. Like any index, it aggregates lots of data and metrics from imperfect data sources. A total of about 130 measures go into this index, pulling from about 60 different national data sources. And we produce the index annually every year for national estimates, state estimates, and then county level estimates. Next slide. This slide just shows you the domains and subdomains that are measured in the index, and and their domains around surveillance, planning and engagement, incident management, healthcare delivery, countermeasure management, and then environmental and occupational health. The domain I'll really focus in is that community planning and engagement domain, and specifically our measures of cross-sector community collaboration. That's the place where the strength of the network is really measured in this index. Next slide. So we can use the index now. It's been produced since 2013, so we can look at trends over time at a national level. These kind of preparedness activities have been improving over time in the average U.S. community, both overall and in the specific domains, but we also see quite a bit of variation across the country in, again, how prepared states and communities are in terms of having these capabilities in place. Next slide. We also see, not surprisingly, wide geographic variation in the strength of these protections that are measured in the index over time. And we can see kind of regional clusters of communities that are stronger and weaker on these kind of protections. Next slide. And so one of the things that we've carried out over the last year is to look at how useful the preparedness index metrics are in actually explaining the variation that we see in COVID incidents and in COVID outcomes across the country by linking our county level estimates of measures of the preparedness index with county level estimates of COVID incidents, and in this case, COVID mortality. And this slide shows you results from those analyses showing you that places that score higher on the index generally had lower rates of death from COVID over this period of time. And in particular, looking at the subdomains measured in the index, it's that community planning and engagement domain that is most strongly predicted with lower burden, lower levels of mortality, in this case from COVID-19, after adjusting for demographic and socioeconomic characteristics, including adjustments for the social vulnerability index that Dr. Mays mentioned as well, and suggesting the kind of things we're measuring in this index are actually predictive of kind of how the COVID-19 mortality patterns have played out around the country. And again, community planning and engagement, the strongest element of this index in terms of predicting mortality from COVID-19. Next slide. Within that broader domain of community planning and engagement, we have several different measures of community network strength, the strength of community networks that exist within communities. And we measure the strength of community networks using another national data source called the National Longitudinal Survey of Public Health Systems, which basically measures how strongly public health organizations are able to work with a variety of other organizations in the community to plan for and respond to health issues in the community. Working with medical care organizations, social service organizations, et cetera. We use some classic approaches to network analysis, network measurement, and measuring the strength of these networks using density and centrality measures to do that. And those network metrics that are included in this preparedness index are the strongest individual predictors of COVID mortality, as we've done that analysis across the country. Again, making the case that these networks, the strength of multi-sector community networks, really matter when it comes to responding to COVID-19 as well as other types of large-scale hazards. Next slide.
Glenn, we have about a minute or so to wrap up.
Perfect. I'm just wrapping up. The last point I want to leave you with is to understand that these multi-sector community networks, which we've shown are really important to planning for and responding to large-scale health threats like COVID-19, are also major users of race and ethnicity data. And they are in many ways limited in what they can do because of the data limitations that we've been talking about in this panel. These networks, as we've done work with them, they rely heavily on small area estimates of race and ethnicity from the American Community Survey, which we heard about earlier in the panel, has high margins of error and other distortions in the data. They're also using administrative data sources of the kind that Dr. Beckmeyer talked about earlier, which are imperfect. They're increasingly trying to reach out and use other data sources. The most kind of emerging data source that these networks are using are social health information exchanges that are being built largely on top of existing health information exchanges that are trying to integrate in data from social service providers, housing, food banks, et cetera. Those are emerging data sources that we feel are promising again, potential solutions to filling in some of the gaps in terms of race and ethnicity and vulnerable populations, and ones that we should continue to look for as a possible solution here. So I will end there. Thank you.
Thank you so much. And I'm sorry to rush everyone because we could listen all day. Next, we'll go to Dr. Stoto from Georgetown.
Well, thank you, Denise, and everyone for inviting me. This has been a terrific panel so far, and I've really enjoyed the presentations and hope I can contribute to it. So if you could bring my slides up. There we go. So the work I'm going to be speaking about comes, if you go to the next slide, please. It draws in large part on the work I did with a committee of the National Academy of Sciences, Engineering, and Medicine that was formed because of the controversy after Hurricane Maria, trying to estimate how many people were impacted by it. And there were a lot of different, very, very different estimates. As we were coming to the end of our work last March, COVID hit. And we realized that a lot of the ideas that we had been talking about in this committee applied to COVID as well. So, and we ended up, Matt Winey and I ended up writing an appendix to the committee report that both illustrated what the committee was talking about and then helped feed that back into the committee recommendations. So I'll speak about really the COVID aspect of this rather than the whole committee report, but the references are there, and I've got some summaries of that as well for people who would like to see the more general version. Next slide, please. So I've been focusing more like what Betty has been on is the kind of data that the public health officials need to make decisions, and it's the metrics. The metrics that we all see in the paper every day that we want to believe are science-based and objective to make and using them to make decisions. They're published by a variety of organizations, government health agencies, universities, the media. They vary in what they present and how things are defined and what they deal with. There have been problems like uncounted deaths that already has been referred to by Andrew. And it really seems that we are flying blind in a large degree against COVID. It's reassuring that actually the first element of President Biden's executive order about dealing with COVID has to do with building trust through developing better data systems. So I think a lot of what I'm saying will relate to that. So next slide, please. Next slide. There we go. So this is the kind of thing that we all see every day. We probably get it in emails from this one's from the New York Times with the situation last week as I was preparing this presentation. One of the things that pops up here, of course, is Oklahoma being blank. It probably was not true that there were no cases of COVID in Oklahoma, but some data system. issue. The week before, Missouri was lit up like a red light, and that turns out to be because they decided last week to count all of the probable cases all at once at that time. So there's all sorts of things like that that happen with these data that make it hard to really have trust in them. Next slide, please. These are important because states, counties are using them to make decisions. California in particular, I see Vicki shaking her head there because she knows that there's a very strict system that the governor has put in place with 4 tiers, and depending on where you stand, there are very different levels of restrictions. I heard that San Francisco people were cheering in the street when they went to yellow last week because of that. So it's very consequential. But these metrics do. But can we trust them is the question. Next slide, please. So, another way that we often see is the number of reported new cases daily. This is over the last, over the whole last year. It of course goes up and down. This was prepared last week. We know that in the last week, it actually has started to turn back up again. But one of the questions that always comes up when you see data like this, is it because we were doing more testing or not enough testing? So if you click once more, please, this shows the number of specimens tested. And it goes up. It was high in that winter peak, but is it high because there were many cases that needed to be to do contact tracing, or were the cases reported because more testing was done? It's hard to sort those things out. Next slide, please. So sometimes people have tried to look at this by using the test positivity rate, simply the ratio of the number of positive cases to the number of tests that were done. It's a very ad hoc solution. It depends on what kinds of tests were done, why they were done, and so on. I won't go into the detail there. If you click one more time, though, a couple more times, there we go. The key thing about this is that both the numerator and the denominator change over time in complex ways that really don't have to do with what's going on with the epidemiology of COVID. So it's really hard to tell what is really going on. So this is an ad hoc and not particularly successful solution. Next slide, please. So why do we have these problems? I think it comes down to the fact that most of the data that we have, that we track, come from case surveillance data. That these are it's a standard public health technique that goes back more than a century. Certain cases need to be reported to the health department, who then use it to investigate or to do contact tracing. That's a complicated activity, particularly when you have thousands of cases like we're seeing these days. And it's hard to get it right. And it leads to a number of problems. Next slide, please. One that epidemiologists talk about all the time is the iceberg effect. We know that only a fraction of the cases that occur, a fraction of the infections that occur, are actually reported. We like to think that, like a real iceberg, a constant fraction is above the waterline, but that's not true because of changing in test availability, differences between states in terms of what gets counted, different definitions, and all sorts of other things, including many things we've spoken about here. This number just is neither constant. That the fraction that's reported is neither constant across states or over time. One of my graduate students has said we really have a bobbing iceberg that goes up and down over time. And of course, the same thing is true for reported deaths as well. And Andrew spoke about these issues very nicely. Next slide, please. So the other problem with it is that the people doing the contact tracing are focused on doing the contact tracing, and they don't always gather the information that we need if we want to study things like socioeconomic differentials. So last month, when CDC wanted to publish some data on racial and ethnic disparities, they took data from only 16 states and big cities that had more than 70% completeness of race and ethnicity information in their case counts, and which is only 30% of the U.S. population. And of course, even some of them they don't have the data. So this is a potentially very biased sample. It shows that Hispanics and African Americans have higher rates. It's probably worse than that, but we just can't tell from data like this. Next slide, please. You know, another approach went also from MMWR last month. CDC, because they don't have the data at the individual level, they said, let's look at the counties that tend to be one ethnicity or race or another and see which ones of those have high COVID rates. It's a very, in a way, convoluted way to get at what we want to know. Next slide, please. So what did we do? These are recommendations from the NAS report as well as mine. So if we want to think about dealing with these, working with these reported cases, we should standardize case definitions, as already has been done, but also standardize measurement processes and metric definitions and time periods for averaging and all of these other very practical things that are needed to make these data comparable. But there's limits to that. Next slide, please. So in the National Academy's report, we spoke about basically building a system to do this better. And I don't have time to go through all the details here. So if you just go ahead 2 slides, I do want to talk a little bit about 3 different ways we spoke about in that report of improving the methods. You know, the metrics. Early on, we sort of have to go with what we have, but now we're a year into that, and we ought to be doing better. And we want to be able to do better the next time we have an emergency of different sorts. So we talked about 3 different methods for that could be done. One is excess mortality methods, and Andrew has done a great job of that. So I'm going to skip over 5 slides, I think. So where I talk about including one of his that will fly by that's his. And I do want to say, if you stop here though, that there still needs to be work done in this area. What we saw looking at the Hurricane Maria and the other hurricanes, and here is that basically every time people come to it, they start from scratch and make up methods. But we think that there could be standardization here in terms of things like how do we do projected expected populations? How do we take into account the fact that populations move? You know, during the peak in New York, some neighborhoods, 40% of people moved out of town. What impact does that have on excess mortality calculations? How do we take that into account? And many, many issues more like that, that if we thought about this systematically, we could use this kind of as a surveillance system going forward to really track things in addition to the kind of explanatory work that Andrew has spoken about so nicely. Next slide, please. Another one is the topic of syndromic surveillance, which is an idea that goes back about 20 years. And the idea is that you don't actually have to wait for people to be diagnosed to be able to have something to be tracked. And so an example of this is where we track people who either come into hospital emergency departments or for outpatient visits and it has been influenza-like illness, certain sets of conditions, but we could also look like COVID-like illness. So on the next slide, this shows some data from the New York metropolitan area last March. And we see the COVID cases in red that go up, that spike up starting in March. The influenza cases in blue, which were of course dropping off at the end of the flu season. But the percentage of emergency department visits that were for influenza-like illness, again, was high in February and down in March, and then back up again in March and April, basically picking up COVID cases that were coming to the emergency department with symptoms that were like flu. And you could also look at this for, this has been refined and CDC is now tracking it for COVID-like symptoms as well. Next slide, please. And then the other idea is that we can do surveys and based on representative sampling. Again, we don't have to count every case to make sure that they're valid. If we thought about, developing a a statistical system from scratch, we wouldn't think about training every doctor and every funeral director in the country to try to categorize things for us. We would develop a system where we focus on some cases and do it well. One example of this is seroprevalence surveys. They could be population-based, has been in some places, or it could be based on things like people coming in to give blood for other purposes, or in certain kinds of clinics like renal dialysis. The next slide, this shows data that was published, this is from last July, of people who were having dialysis around the country in different places. And we see here in July, this was mainly picking up people with antibodies who had been exposed earlier in the year. So it was very much focused on the Northeast and New Orleans area there. But we also can use this because there's actually very large samples here to break it out and to look at disparities. So it turns out that the seroprevalence rates were substantially higher in zip codes that had high Black and Hispanic populations and high level of poverty and high population density. And I suspect if you looked at the kind of deprivation indices that Vicki was talking about, you would see a disparity there too, if they had done that kind of analysis. Next slide.
1 minute warning.
Okay, I'm almost done. The Census Bureau set up its pulse survey early on based on existing sampling frame, and they were able to look at things like food insufficiency. The next slide shows how that varies by different racial and ethnic groups. The key thing here is they were able to build on an existing population sampling frame, and they used they used questions that had been they weren't developed in advance, but they could be developed in advance. And what we are calling for in our Academy report is to have a system set up, ready to go to do this kind of thing. So the next slide is the final one. I think that managing the pandemic requires detailed objective data on the level and the rate of new infections. This better information starts with standardizing current case definitions, measurement processes, metric definitions. In other words, the things that we were talking about is good research methods. In particular, having a constant reference population is really important and often missing in the current metric systems that we have. But in addition to that, there are a number of research-based methods for doing estimations that can supplement and complement these counts that we look at so much: excess mortality, syndromic surveillance, and surveys based on representative samples. This last set of estimates is still largely experimental. And I said, research, it tends to be one-off approaches. So research really is needed into developing the best methods, how to standardize these approaches. And also, we think there's an opportunity for the federal government to develop kind of a framework that can be put into place immediately after a hurricane or as soon as a pandemic starts, so we can really track these things in an ongoing way. The last couple of slides give a little more detail about the report, but when you get the slides, you can look at those things as well. So I'll stop at that point. Thanks for
Thank you. Thank you, Dr. Stoto. We'll go on to Inez Ponce, and we're tight on time, so we'll move right into her presentation.
Thanks so much. Next slide, please. I'm going to focus on, so if we don't make it to the end, here are the takeaways of the presentation. Data disaggregation equals data equity. I'm focusing on the Philippine XAO population within the Asian rubric and that invisibility of this particular population in the Asian aggregated category has implications, as well as implications of the invisibility of Native Hawaiian and Pacific Islander populations. Within this Asian Pacific Islander category, a residual category, or not reported, that we see so often in government statistics. There's also this underrepresentation of Asians and NHPIs in one of the metrics that Dr. Mays had talked about earlier, and it's the California Health Equity metric called Healthy Places Index for vaccine allocation and other public policies, and then the way forward. Next slide, please. So data equity is, the definition is that that data is collected, analyzed, interpreted, distributed, such that the most marginalized communities have access and can use these data. So it's not about the average consumer having to do this, but the marginalized communities that have low literacy, limited English proficiency, do not have access to broadband. It is a global imperative. It's not just in the United States. It's not just also about certain counties in the US, but this talk focuses on the US, Asian, and Native Hawaiian Pacific Islander racial ethnic data equity and COVID-19, which I've been tracking and following the past year. Next slide, please. So I don't think I have to remind people about the OMB Directive 15, but 1997, there were revised standards with 5 minimum categories. I point out that the Hispanic or Latino, not Hispanic or Latino, again, is a separate question, and then 5 racial ethnic groups, and that Native Hawaiian Pacific Islander are a separate group from the Asian category. The OMB is a minimum, these categories, and that there's actually language in the Federal Register that encourages that, that we shouldn't limit collection to these groups, and further details encouraged, particularly if it's imperative to represent the diversity of local populations. Next slide. So back in July 5th, 2020, it was, the reports on the inequity of the coronavirus. So this was the fullest look yet back in July 5th. And the populations that were reported were whites, Blacks, and Latinos, and for the entire population. Next slide, please. But back in July 2020, you can't say there was no data, because at that time there was data that showed that actually Native Hawaiians and Pacific Islanders, they're the dark orange line that's on the top, we're already showing high case rates, case per 100,000. And as you can see, as we continue to track this group through February, March of this year, that this case rates continue to escalate. And in fact, even along with the Hispanic population, in California, continue to have a steeper surge than the other populations. Next slide. Another type of invisibility is that because public health systems do not report disaggregated Asian categories, that what we know about the pain that's suffered by some communities is only found in online tributes or GoFundMe or Facebook and Instagram. So this is a website of an online tribute for the Philippine X health worker population, not just in the United States, next slide, but actually globally. As we can see, though, that the United States is the epicenter of where the loss of healthcare workers are in the Philippine XAO population. Next slide. And yet it is not available in public-facing data, but it is available, like this insight is known from special surveys like the Guardian Kaiser National data that lists the Philippines as the top of immigrant health worker deaths, from a National Nurses United survey that 4% of the RN population are Filipinos, but 31.5% of RN deaths are Filipinos. And then from my access to restricted data that took many months to get, that 3% of the population in California of the population are Filipino healthcare workers, and 31% of healthcare worker deaths, mirroring very much the National Nurses United survey. Next slide, please. And in terms of case fatality rates, the severity, and I know like technically it's a deaths per case ratio, but we're seeing that also the Asians do have the highest death to case ratio among the major OMB groups at 1.18%. But if you disaggregate that, again, this is my view of restricted data, that Filipinos actually are the ones driving that at 6.4% case fatality rates. Next slide. Next slide, please. So moving on to Native Hawaiian and Pacific Islander population. Next slide. Where they disaggregated, and this is something from the NHPI Data Policy Lab that with the NHPI community, I helped stand up during the COVID pandemic. And it shows here that it's only the orange slides where there's actually any data on the NHPI Pacific Island, NHPI population. All the grays they are not available. And so it's about 20 states. Next slide. So when we think about this vaccine framework and the equitable premise and the criteria, so we know that from ACIP that there should be aimed to reduce existing disparities and not create new disparities. And from the NASEM report, that you want to ensure that there's special efforts in these high vulnerability areas. Again, now moving to this place-based metric. And based on the Georgetown report, and I don't know if Mike Stoda was part of this, was the 18 states have used an equity metric for vaccine allocation. Next slide. This was as of December. There may be more at this point. Dr. Mays talked about some of these place-based vulnerability measures. I just point out because I'm going to show us a map on the next slide that I do look at the go back to the last one. Social Vulnerability Index is the only index, at least in these 4 that I'll be showing in the next slide, that explicitly have an input of minority status and language. The Area Deprivation Index does not. The Healthy Places Index, which is what California uses, does not. And the Pre-Existing Health Vulnerability Index, actually, the medical vulnerability does, that Dr. Mays was part of, but the one that we've had access to also does not have minority status and language. Next slide, please. And looking at multi-generational households and looking at limited English proficiency, for example. So this is really hard to see, and I apologize, but the main point here is that this is a tool from the California Health Interview Surveys, a survey that I run, and it's called ASCHIS Neighborhood Edition, and we have this at a track level, and we put all these indices in one place to see how it performs. I chose a tract in Carson, California. It's a high Native Hawaiian Pacific Islander population area in California. And I can't even see it, but you see that there is only one of these vulnerability indices, the XVI, that actually then allows, that tells policymakers that this is the thickest quartile and that there should be some priority. The others do not. Others miss out of it, miss that. Next slide. So I looked at underrepresentation then in using the HPI, which is the Healthy Places Index, which is in full force right now, not just in reopening, but in vaccine allocation. And next slide, just to get very quickly at this, because my 5 minutes just rang. So looking at each county, I looked at the sickest quartile of the HPI and looked at the communities of color that were underrepresented. The good news is the Latino, Latinx, Hispanic population is not underrepresented by using the HPI, but the other communities of color are underrepresented, particularly the Asian population and the NHPI population. Next slide. And this underrepresentation, however, then juxtaposed with this overrepresentation in the toll in the cases and deaths of NHPIs in particular, then is really concerning for this community, for the NHPI community. Next slide. When metrics then overlook the need of a community because they're not geographically clustered, because they're so small. And so these place-based metrics that do not include the social dimensions of pain for some communities then just really miss out the opportunity to address their needs. So I suggest that we enhance place-based equity algorithms, that they need to be augmented by other domains such as limited English proficiency, linguistic isolation, language spoken at home, per capita income, per capita versus median, because a lot of immigrant households have large number of household members, immigration status, frontline essential workers, proportion of multi-generational households. This is, again, also would get at the susceptibility and the spread of COVID. And it's a race ethnicity, it's a public health emergency response. California's reasons for not putting race ethnicity is political, but I believe that there should be a public health emergency response to override this. And then just then two considerations, do we model as a factor, or do we layer this HPI with other criteria? And I do like Glenn May's community engagement, community systems criteria, because at the end of the day, then you're going to want to, it's going to be mobilized through community effort. So the last thing is disaggregate, please, particularly for the Filipino XA community. Next slide. Thank you.
Thank you very much. And we will go on to Dr. Cullen, but before that, we will extend the session here. I think our chair has given us another 30 minutes as if we need it. If a panelist has to go, I know you were booked for a certain amount of time, feel free to do so, but we don't want to let this topic go just yet. And so we're going to extend our agenda time to, I think, 4 o'clock. So Dr. Cullen?
Thank you. Can you hear me all right?
Yes.
Great. Anyway, I want to thank you, Denise, and the other organizers for inviting me to this fascinating panel, and to congratulate those of you who've spoken before. I'm learning a ton, and that's what makes it worthwhile spending a day on Zoom. I do, before talking about the solution that I'm going to present, which I think only some of you are probably even vaguely aware of, I just want to point out the very different needs we have for granular and accurate data, down to the level of very accurate reporting of race and ethnicity. So much of it obviously is for public transparency. Several earlier in the first panel talked about the critical nature for politics and everything else to be out of the way, so that the public can, on an almost daily basis, see exactly what's going on down to its social ramifications. That's one important use of this granular data. A second very important use, obviously, is for the practice of both clinical medicine and for public health on a day-to-day basis. I'm not going to be talking about those. I'm going to be talking about a third need for extremely high quality granular data, which is for the purpose of doing the research which underlies many of the things that a year into the pandemic we now take for granted, because so much of this research, I think now over 200,000 papers in preprint or print, have appeared in the course of the year. And it's to this end that I think the consortium that I'm going to describe to you represents at least a partial and interesting and to some extent unique solution. So the basis of what I'm about to describe to you is, of course, not premised on anything that government does or anything of any of our vaunted agencies do, and certainly not the interests either of physicians or public health workers in the country, but the remarkable reality of our healthcare system in the US, which, because every dollar is counted and the system itself is driven by money, we track, not for any reason other than commercial, virtually every single activity that occurs within the healthcare sphere. And it turns out that literally dozens and dozens and dozens of commercial enterprises, ranging from small to massive, are involved in this. So all of you know Epic and the large insurance companies and the like, but are probably unaware of the many, many other companies that participate in the collection of data from where various forms of transactional care occurs, whether it's telemedicine or a visit or whatever, all the way out to the roll-up of those data that are mostly handled by very large organizations. And it is in this vein that at the very early onset of the pandemic, literally in March, many of these companies who interact with each other, both as competitors and as clients, got together before I was involved in it and formed a loose consortium, 30-odd companies, in which the goal was to pool all of their data. This is extremely granular data, including the kinds of details that would make most public officials blush in terms of its privacy and security ramifications, but to pool this data in a safe way and to develop a method by which that data linked together in appropriate ways could be made very rapidly available to the research community. And the principles were that the data had to be granular, that links had to be available, although never made available to researchers, but available so that data sets could be effectively linked. The quality of the data was important, so this had to be commercial grade data. It doesn't have by any means perfect reporting of race, ethnicity, but it's far more complete than in a wide variety of comparable publicly available data sets. The companies had to commit to making the data refreshable on more or less a weekly basis, so that researchers would not be studying last year's outbreak, but last week's outbreak, and so the data are of that kind. And then most importantly, developing a scientific review and administrative oversight using technology that can secure the privacy of these data to make them very rapidly available. So I'm going to talk about the research database, affectionately known as the COVID-19 research database. You can see on this slide the website. I would strongly encourage those of you who are not aware of it to go out to the website and to register, so you can actually see the full spate of both the data sets and the procedures. It's very open and transparent. Next slide, please. So this is just a sort of a structure of the way these so-called real-world data sets are put together. Again, a three-part process in which a privacy, security, and compliance review, a scientific review, and then a proprietary review by the contributing data sources can occur within about a 2-week period of time, from a very short application procedure to having provision of the data in a secure and enclave environment. Next slide. So this is really just a schematic overview of how we manage this remarkable process. Just to put in perspective, there are now something like 5 or 6 billion records in there, and it covers about at least partial information on about 90% of the US population. Unfortunately, there are pockets that are not available, so that, for example, people that are totally uninsured, undocumented and so forth are less well represented, but major swaths of the population at every level of their insurability are available. Next. So this is the structure by which the data are put together from a technical infrastructure point of view. I'm not going to go into the technology that allows for the stripping and tokenization of the links so that they're available to the data managers of the system, but never to any of the investigators who come on the platform. Next. So these are some of the key players. So among the 35 organizations that are now involved, almost all of them are for-profit proprietary organizations. These 6 play unique roles. DataVant was the originator and the host and the original organizers of the database. HCCI, that many of you know, is a not-for-profit that has a long experience in the management of healthcare data, and then 3 companies that are in the IT business in health. Next. So this is an example of or an overview, I guess, a sketch of what is available in these data. I would not for a moment claim that these data are perfect, in the sense they don't cover complete populations virtually anywhere, and many of the data sets have varying degrees of quality for important fields, including the field of greatest discussion today, race, ethnicity, although not surprisingly, the private sector has taken this particular field, and many like it, quite seriously. In particular, the data sets are linked to data sets containing social information, in which these variables are very well recorded. They are probably not perfectly disaggregated per the previous speaker, for which, obviously there's a lot of improvement for future work. Next. So this is what we've achieved in the first year, just in terms of gross numbers. So about 2,200 people have registered for the data set, or 2,200 groups. 150 have made active research proposals, and right now there are 400 different researchers as of like literally today that will be working on the platform, each with their own unique area to manage their folders, to access the extraordinary range of tools on the workbench, and to maintain data for review prior to any downloads that are done, which we do internally review, again, for privacy and proprietary considerations in that setting. I will point out this is all completely free. So that the companies obviously are expending both personnel resources and money. AWS contributes cloud credits, Snowflake contributes credits. Virtually all of the companies provide some major personnel or other resource to the
Mark,
enterprise.
1 minute warning.
I'm almost done. Next. This is just to give you an idea of who is taking advantage of it. I just want to highly emphasize the first line. So we've had many applications from public agencies, partly because these data are richer than many of the available data sources in terms of granular detail, especially in areas like health services and clinical data, because we have tens of millions of EHRs linked to some of the claims data. But you can see that a wide variety of both domestic and foreign groups have joined this enterprise. Next. And this is just a just quick overview of some of the more salient publications and other releases of data that have emerged from the study, ranging from very granular studies of particular diseases to possible secondary uses of medications that were originally designed for other purposes, so-called repurposing, and then, as I said, an extraordinary range of health services related work. So I will stop there, and hopefully in the discussion I can fill in some questions, as long as you're all kind enough not to ask me too much about the IT technology, because I take a lot of it at face value. Thank you.
Thank you.
I want to thank everyone for these stellar presentations. And I hope that my colleagues are just brimming with questions, which I have a feeling they are. So thank you, Nick, for some additional time. What we're going to do is ask you to use the raise hand function. And we're going to start with questions from the committee and then move to others who are also in a position. And Rebecca's going to help us as well in terms of if questions are popping up, in other places, so that we can kind of try and stay focused. Okay, questions, comments?
Valerie.
Oh, okay.
Yes, thank you. Thank you. This was so fascinating and yet alarming too. And my question, I think, is for Beth, in your first presentation. I think you said a few things that really resonated, and I think it was on slide 16. You were talking about imputation there. And I just had a question as to how you decided to use that particular method that you chose.
Well, I think that it's basically just the simplest method to use. And there's a very fundamental assumption behind it. The assumption is that the people for whom we don't have race and ethnicity reported with their case status are essentially the same as the people that we do have race and ethnicity reported. So, in epidemiology, we like to be conservative, right? So if we're going to make an error, we want to err in the side of biasing towards the null. So, you could make an argument, well, maybe racial and ethnic minority populations are more likely to not have their race recorded. So if we take the distribution of the known cases and apply that distribution to the unknown cases, maybe we're underestimating the number of racial and ethnic minority cases. But if we are doing that, we're making a conservative assumption and we're biasing towards the null. And I think the real problem is that we just don't know why we're not getting this data. Is it a problem at the level of the laboratories that are doing the testing? And I think, you know, it's not a scientific problem, it's a policy problem, it's a systems problem, but we need an investigation. We need to systematically investigate the patterns of missingness down to the local level. Is it only certain counties, or is it only certain labs that are not reporting and the other labs are doing a good job of reporting? So once we investigate, then we have the data that we need to try to change it, whether that, you know, is an incentive that needs to be paid or whether there's a consequence that can be given to say, hey guys, you got to do a better job on this. But it's kind of depressing to me that after all this time, and we've known that this was a problem for months and months and months, that it's still a problem, that it still hasn't been fixed. So it needs to be more actively addressed. Not just talk about it, but someone needs to go out and actually do something and make somebody change what they're doing so that we get these data.
And just one real quick follow-up, but then I'll be quiet. Did you also notice this and you were able to use that same type of, you know, the same type of imputation for other age groups as well? I know you said we should go to your website to find that, but
I mean, our website is the Cove Kid Project, so it's just focused on children and teens, but the problem is exactly the same for all ages, and the exact same method can be used. Now, I will say that the racial ethnic distribution of cases and deaths varies highly by age. And the younger you go, the more racial and ethnic disparities you see. Because in the elderly population, we have a lot of white elders in nursing homes and assisted care facilities who died from COVID-19. So when you look at 65 and older and 75 and older, there's not as much of a racial disparity. But when you get down to young people, young adults, teenagers, and children, and even infants, the disparities are very great. So the imputation has to be done by age and by state, whatever method you choose to use.
Thank you. Thank you so much.
Sure.
Woo.
Oh, hi. Hi. I want to thank all the presenters and the organizers for have this informative and insightful panel. So I'm more thinking related what committee's action come out of this hearing. So my question is to the Seth and the David and the census, the presentation. I'm surprised, but I'm happy to know this census decision on which data elements to improve is a policy decision on the allocated fundings. So I want to make sure I heard right. So far they are focused on redistricting and also the Hispanic population data quality improvement, right? So it's not all the race ethnicity data improvement. Is that correct?
Not quite. I think the use cases that the Bureau has been privileging for the 2020 decennial have been redistricting, which is all race, all 63 OMB race groups, ethnicity, voting age, either above or below 18. And those are the three main ones. And then the next set of policies is when we talk about race, it's going to be for all race groups. It's at the variable level. Seth was presenting on kind of Hispanics as a illustrative group for the ACS. But yeah, the Census Bureau is going to decide that, you know, we're going to allocate privacy loss budget to particular variables. And because it's a fixed pot, if something gets a higher allocation, something else by definition will get a lower allocation. And that is a decision that's made by an internal Census Bureau committee who's taking input from stakeholders, like the committee could provide a report on what they think is important. But that committee is going to have to balance, the Bureau will have to balance out all the competing interests of all the groups.
Okay, thank you.
Yeah, just to add, nothing's been set yet in terms of the 2020 decennial and how they will allocate this privacy loss budget. It's a new idea. It does make explicit certain kinds of trade-offs that really haven't been explicit in the past. And I don't know that the process by which they will make the final decision is set. I believe there will be an open period for comment that they've recently announced.
Thank you.
I just need to note that this committee reports to HHS, and census is in another department. So that's just, if you wanted to make recommendations to HHS to do something with commerce, that would be fine, but just to make that clear.
Rebecca, because I want to follow up on that, and it really is a bridge. Just so that we're clear, all of the NCHS data sets are based on census data. So it's almost like it is in the best interest in terms of our data to really think about what the implications are from census. Seth, you started to actually go where I had a question, and that is, have you or others started trying to model out the implications of the potential new privacy differentiation on specific racial and ethnic minority populations? Because I know for us in California, we're particularly concerned about the American Indians. I'm sure that the smaller Asian Pacific Islanders, and what that's going to mean for us in any data that has census as the basis for our estimates.
Yeah, so there was a workshop held by the Committee on National Statistics in kind of December, and those workshop proceedings have been published. Those were based on an initial release of this new approach. Both the videos and the report there are up, and there was a lot of looking pretty carefully at specific subpopulations and the implications. Overall, it wasn't a great story. I think the Census Bureau took that to heart and worked on improvement. On Tuesday of this week, they just had a webinar in which they tried to sort of talk through some of those improvements at a high level. Those slides, I believe, will be publicly available. They had a lot of different approaches, and there really wasn't, there were trade-offs among the approaches. I think that I don't have a strong enough handle on the results yet to really summarize them quickly. Other than that, there are a lot of trade-offs that they're trying to balance across, I think.
And I'll just quickly jump in and say that we as of today, and in the Tuesday presentation, the Bureau said that they do not plan to release uncertainty estimates for the decennial 2020 population counts, at least as of right now. That could change. But once we know more information about the process, we'll be able to roughly estimate uncertainty, but their methods are pretty complicated. The noise injection is pretty straightforward, but then they have to do a lot of post-processing, and that introduces a whole other set of issues that we can't easily model that uncertainty. But I can tell you that that's going to be a hot topic of research over the next 5 years because it's so new. I'm sure Seth and others and I will be continuing to work on that over the next little bit.
Can I ask you another question if I don't see a hand up? But after this, I want to make sure that the panelists get to ask each other a question. This question is actually for Dr. Cullen, and it has to do, I'm aware of the data consortium that you're talking about. And it really gets into these new privacy kinds of concerns that I think people have been struggling with. In terms of a review by the IRB doesn't have jurisdiction over the mesh up, but this is under this whole auspices of big data. And so the IRB doesn't really have the jurisdiction over this because it's de-identified. There's no PHII in here. But at the same time, populations, particularly racial and ethnic minorities, have been concerned about for-profits and all others utilizing this data, and for the small populations, what potentially could be publications that end up being somewhat that have a negative blowback to it. And so part of this big data issue has been this notion of who's protecting and understanding racial and ethnic minority issues, who's protecting and understanding how data is used or sold. And so I'm wondering if you could talk about this, because this has been the discussion about the mix of that data. And many of us are kind of concerned that we not lose public trust. So those things that are going to make sure that that doesn't happen, maybe you could explain that, because the public is very interested in this mashup of data.
So Vicki, it is the $64 million question, and I'm probably not going to be able to completely satisfy you. I spent, just by way of context, I spent 5 years at Stanford building, not for COVID, this predated COVID or just came to the brink of COVID, trying to develop highly linkable, extraordinarily rich, granular health data to make it available to academic researchers, both our own and as widely as we could do it. Under those auspices, we were beholden to the compliance and privacy offices of our own institution in the academic setting. As most of you who are in academics know, they are extraordinarily risk adverse. So many projects that could have happened didn't happen for that reason. The private companies have developed a technology that, at least from the purpose of the researchers using the data, they're blind to any identifiers, and before they can download data, another review is done by the governance, privacy, and compliance group that is intended to do much what goes on at the FSRDC level, which is to look at cell sizes and to make sure that nothing is being reported that would result in a cell. The usual sort of cutoff number is any cell under 50 is not generally accepted. But having said that, the standard is tethered to the legal risk tolerance of the contributing companies, and I guess the good news is that they are pretty risk adverse in terms of that, so that we have lost a couple of projects, at the compliance step for probably good reasons. Although, as the head of the scientific steering committee, I'm always pushing in the direction of trying to learn more, but we get pushback. But it is a matter of public trust. I mean, I can tell you, having looked at the output so far, that I think we have done an incredibly good job in avoiding anything that would even come close to a worrisome line in terms of cell sizes and things that would raise those concerns. But the flip side of that is we have not gotten into very small populations. So I'm unaware of, although several of our investigators are quite interested, for example, in Native Americans and in some of the sub-communities within the Latino community and also within the Asian US population. We have not had publications, for example, that look at Filipinos or that look at Pacific Islanders specifically, separating them out from other groups. So, I mean, I think we're in the same, we will find ourselves in much the same boat that the whole field does. What we haven't done is try and distort the data through differential privacy or other forms of corruption of the data for the purpose of making it safer but more useless. I mean, that's a trade-off we haven't yet made. But this is a real conversation that we're not any of us going to be able to avoid. I mean, that's
Nick.
Yeah, I have just one question. I'm not sure exactly who it would be directed to, but if we assume for the moment that all of the places where the data is gathered were perfectly willing to provide as much data as they could, is there enough information regarding what would need to be provided in education to make that happen? I'm trying to understand the differential between either a willingness kind of question, if you will, versus an ability and understanding to do that. And then there's some of the kind of technical or semantic consistency questions that might arise.
Can I respond to that? From the point of view of the kind of the case-based data that I was talking about at the beginning, that's generated by public health, local public health people who are really busy in the middle of an outbreak, and getting them to generate data that they don't need for their immediate activity, and doing it kind of in a research quality way is really hard. I've been working with the public health people in Martha's Vineyard, a population of about 20,000, that a substantial fraction of whom are Brazilian. And it looks like there's the outbreak in the winter has been in the Brazilian population, but it's really hard to tell because they basically have stopped gathering the data that we need, the identification, as they got busy. So it's really hard to tell. So that's why I think we have to find another way to look at it rather than those case-based data.
Beth, you had your hand up.
Thank you. I think that there are a lot of technical and logistical problems at the state and local level. A lot of them deal, the capacity to deduplicate because you have multiple tests happening for the same individual. You have delays in reporting, and there's a lot of issues with dates, and a lot of our surveillance is very date dependent, new cases, new deaths, but actually it can take a variable amount of time for deaths to be reported, for tests to be reported. We know that there are situations where labs will rapidly report all their positive cases, but there are delays in reporting their negative cases. So then this dramatically implicates the test positivity rate. So the test positivity rate can fluctuate on a totally artificial basis because of delays of labs in reporting negative cases to the state, not positive cases. So there's a whole range of really thorny, complex, technical and logistical issues. There are issues around definitions. Not all people who are COVID positive cases who die have COVID-19 as a case of death, as a cause of death. So there's COVID-19 as cause of death, and then there's deaths among COVID cases. And those overlap to a great degree, but not 100%. And different states define a COVID death in different ways. So, I would say that it's everything. There are more resources and standardization and kind of consensus on what we really mean about all these different measures are needed across all of the states.
Denise, and then Nanez. Did you take your hand down? Yeah, Denise Love, did you take your hand down?
Yes, mine's down.
Okay.
It was answered, so we'll go to Nanez.
Well, I think, to get system change, you either have a mandate, an incentive, and you have guidelines on how to do it. So our issue in California is that we do know that there is collection of race ethnicity at more granular levels than OMB, but it is not reported out by some local health departments and by the state health departments. But yet California has a code that you're supposed to collect more granular. And actually in the education statistics world, they actually are told not to collect Asian, for example. They have to go through the subcategories first, and that Filipinos are separate. So there's mandates and there's incentives. With some of the COVID money going to counties, if some of that could have been tied to either better, more granular data collection, and I'm not talking about my world of data disaggregation here, or again, like partnering with representatives of community organizations that would really say, you really need to do this. You really need to look at this population that's overlooked. So but standardization, so having guidelines on how to do it, and there are guidelines. I mean, I worked on a guideline for NAM in 2007, on guidelines for standardized race ethnicity reporting, collection and reporting back in 2007. And it talks about the roll up as well. And it's surprisingly, it probably is in statute that a lot of states are supposed to collect more than OMB guidelines, but there's no appropriations money or there's no incentive.
Margaret.
A quick question. I heard discussion about cause of death, but on our death certificates in this country, the bottom line is underlying cause of death. And I worry about the data that's been happening over this past pandemic and how consistent that is statewide or nationwide in terms of underlying cause of death. Because it's like saying heart failure. Well, who didn't die from heart failure? But it was due to. So I don't know if any of the panelists want to comment on underlying cause of death for COVID.
Andrew?
Well, I will defer to some of the others on the panel because I see several people raising their hand. So let me defer to the experts here.
Elizabeth.
So I've done a lot of work with mortality data over the years, and Andrew, I really appreciated your presentation and mentioning the issue of home deaths. And of course, part of that also is outpatient, what is coded on the death certificate is outpatient emergency department deaths. And this is a large portion of COVID-19 deaths. And as you know, when a patient comes into the emergency department, they can only stay there for 24 hours. So, and then they have to be admitted or they have to be sent home. So if someone dies in the emergency department, it means that before they crossed the threshold of the hospital, they were already actively dying. So this is a failure of medical care and a failure of rescue when we have people dying in the ED. The ED is not a place for people where people should be dying. And classifying cause of death is very difficult when we have limited medical information. I know Andrew used the term garbage code, but I just want to push back on that a little bit. I know Dr. Murray at UW has popularized this phrasing of garbage codes, but I think it's problematic because the codes that they're referring to, which are symptoms, signs, and ill-defined conditions, and it's a family of codes when there's inadequate clinical information. So it's not really garbage, it's that whoever has to certify that cause of death does not have enough information to know why the person died. And when people with lack of access to medical care, maybe they don't have a regular physician, when they die at home or they die in the workplace, or maybe they die in the ED before the family can arrive and any information being given, the person who's writing that death certificate really may not have enough information to say why they died. They may have some suspicion, and then people will vary in terms of whether they'll just say, oh, well, we don't really know, so let's call it heart disease. And that's a very common thing that happens. Or they'll use these symptom, signs, and ill-defined codes. But I will say, in direct answer to your question, when researchers have access to death certificate files where they have all the so not a tabulation, and all we have right now from NCHS are tabulations. But if we had access to actual death certificate files, you will have both the underlying cause of death and contributing causes of death available for analysis. So that information does not have to get lost. If you have adequate data to look at, you can look at both and see, whether some people are more likely to get that contributing cause versus the underlying cause for COVID-19.
Okay, before I turn it back over to the chair, I just want to see, Rebecca, do we have any comments and questions that we need to take from our Q&A?
Yeah, Vicki, so I think I'd like to read into the record one in particular from Ruth Wangaren. She wrote, I rarely hear anyone explain the limitations of comparing statistics about COVID that are derived from testing for infection. Rarely are differences in testing coverage from one neighborhood or race, ethnicity, or age to another reported, yet cases and percent positives in these different groups are compared as if they're comparable. Unless the population of a zip code, for example, are being regularly and randomly tested and across all age groups, how can we interpret statistics like number of cases or cases per 100,000 or percent positivity in the population in that zip code? Clearly, the US never got the ideal surveillance system going, yet even professionals talk about the statistics as if they are real. In some populations, people are rarely tested, even if sick. In other populations, people are frequently tested just to make sure they're not infected. These differences in testing are related to race, ethnicity, and especially socioeconomic status. And then she continued, the test positivity rate is being interpreted as a measure of prevalence in the community, but it's not comparable from one community to another because it depends on rate and thoroughness of testing coverage.
Any comments from our presenters?
I just absolutely agree with that. Thank you for that. I was just going to type, but so in interest of time, it's also some populations are not getting tested because they fear for their lives for being blamed for the for the Wuhan virus, and so we are hearing that there's under testing in the Asian community.
Rebecca, with the remainder of the comments, there are many more actually be read into the record as well.
Well, this is an anomaly of Zoom. Normally, if we were in public, this wouldn't even be possible. So I think there's one I will read when we get to public comment. But other than that, I think that's the one that I think it's relevant at this time.
I think that actually, if we're going to read some into the record, they all need to be read into the record at some point during the meeting.
Okay, well, we can append them to the meeting summary, Melissa, in terms of being legitimate.
I was just going to say, let's just see if we can accept them and that they will then be in some format for us.
The meeting summary, yeah, the official meeting summary that gets signed off on and posted on the website.
Great, so that'll be available. So
Tammy's hands up. Do you have one more, Tammy?
Just one quick question. I mean, we spent many years trying, when we were looking at healthcare standards, to really understand that clinical use cases and administrative use cases use the same types of data. And when I hear all these presentations, which were amazing and scary at the same time, it seems like it's the same data. And is there any efforts or any consideration of figuring out what is the base source for certain types of data elements so we can increase the accuracy? I mean, I know race and ethnic is collected in a lot of different formats. We heard real estate here. We heard, there's a lot of different industries. How do we harness this data to increase the accuracy for research, public health, healthcare, real estate, all the different types of sectors, because this is basic data that's very difficult and expensive to collect. But again, this is just a naive comment. Would love just some guidance on that.
Sorry, Mike, you've got your hand raised.
I'm sorry, Nanez, do you want to answer? Since you do this in the California Health Interview Survey?
You want me? Well, first I would start with, I don't think it's expensive. I think it's and I bring education statistics again. I think it's an imperative that we continue to collect race ethnicity. But how do we do this? I mean, we do it as granular as possible in terms of collecting, and then of course, because honoring disclosure risk. Honoring that, and then we present data as best as possible, for as many groups that are reliable and that ensures that there's no disclosure risk. I'm not sure if I'm really answering your question about like how do we save the public health system, but I'm sure there are other panelists here that could comment on that.
Well, and I see it as being more than the public health and more than research. It's actually all industries who use this type of data, right? There's a lot of dollars. And if we're putting a lot of dollars in all the different sectors to collect this data, it's an annoyance for each of us who have to put it in several times, right? How do we harmonize across these industries that need this data to get our increased accuracy in the research and public health and healthcare where it's needed? Not that the other sectors aren't important. I don't mean that.
I'm going to just say that I don't know about across sectors. I mean, I can't get my brain around that. But I've always had a dream that in healthcare, we could do a better job of centralizing the collection and then having that carry through the healthcare. And one of the examples is enrollment. I mean, that is a low stress time. It's when somebody can self-report their data. And it just like at the birth record with the mother, those are potentially useful sources that could, through linkage and following the healthcare claims, flow through. But we aren't doing that right now. So that's just my 2 cents. I'm frustrated that we can't do it at the point of enrollment at least and start carrying it through.
Well, and that's interesting because if it would be an enrollment, there's less of an incentive not to be accurate because there's not a disincentive for answering in a certain way, right? Hopefully.
Well, I mean, you can argue, there's always a disincentive and always a concern. And I think that's another thing is culturally we're overcoming, but I won't get into some of those discussions I've had over the years. Wu, you had your hand up.
Yes, so it's follow up the discussion, and we heard on the incentive several times from different panels and the committee members. So for incentive to the healthcare providers data collection, so I wonder, we haven't invited Medicare and Medicaid to tell us how they raise ethnicity data in their system. I think they really have power, give incentives to the payers and providers to get better data. So if payer provider working on the Medicaid, Medicare enrollees, overall their system information will become more complete and secure and accurate. So it's a comment for incentive part.
Yeah, I hate to say patient ID, right?
we don't have time for that. Glenn, you're up.
Yeah, just a brief comment that I think there's also information loss in the kind of chain of custody as health information gets exchanged. When you think about the provider who orders the COVID test may have race and ethnicity well documented in the electronic medical record. That order goes off with the sample to the lab, could be the public health lab, maybe a private lab. That's an opportunity for that information to get lost. And then when the results get reported back by the lab to the public health agency, that's one place where race and ethnicity data just get lost, get separated from the other pieces of information.
Good point. Okay, I see no other hands up, so I think at this point what I'd like to do is to thank our participants. Our cup floweth over in the sense of the great information that you gave us for us to really think about, and the specifics that you provided of kind of what some of the gaps are as well as what some of the solutions are. So on behalf of the committee, Denise and I thank you for the seriousness by which you took your duties of providing us with some directions and not just identifying problems. I will then turn it back over to Nick.
Thank you, Vicki. And again, I want to thank all the panelists and participants there. It's very informative. Someone else used the term earlier. It's really interesting and really scary at the same time. So, but thank you again. Now, I think we've got a few things left to do today, but we've all been sitting here for a while. So I think we need to take a break, and we would reconvene at 4 o'clock to wrap up a couple of remaining topics we have, and then provide some time, obviously, for public comments at 4:45. But we will now take a break officially until 4 o'clock. Appreciate everybody being back on time so we can wrap up our day. Thanks again.